Very good morning, everyone. If you could switch on your camera, that will be good. If not, that's fine. Right, let us start. Chay, yeah. Very good morning, everyone. To introduce myself, I am Dr. Manikandan Kathivel, one of the consultant surgeons, HPB transplant surgeon at the United Kingdom. And on behalf of the team PrepMedico and faculty members, I welcome you all for this first ever meeting from the PrepMedico side in the orientation and introduction to the SCFHS Consultant Interview Preparation Program. So let me share I have one of my faculty colleague, Chaib, is here, and as we run through the next 1.5 hours, we might have a few more faculty colleagues who will be joining the meeting as well. The whole purpose of today's meeting is we have been planning a kind of a program for almost 1 to 1.5 years. I had personally had a chance to associate myself very closely with candidates who have been preparing for the SCFHS consultant interview, and I came to understand the system of how the exams work in the Saudi Council, as well as the way we could help in making the candidates successful in their interview. I also welcome Dr. Adil Mohammed, who is also one of our senior faculty in the group. So let me share my slides, and then let me brief what we are going to do today. Just a minute. Sorry, guys. Just a minute. Let me stop presenting. Let me put a picture in picture. Right. Fine. So as I introduced myself, I am Dr. Manikandan Kathivel. I work at the Royal Free and the Whittington Hospital in London as a HPB transplant surgeon. And I'm also the program director for PrepMedico. So for people who are new here, so PrepMedico is an online and offline in the United Kingdom edutech firm, which was started in the United Kingdom by a group of surgeons, mainly to mentor and train candidates appearing for the FRCS exam. We started this mentorship program 4 years back, and we have been doing very well with the FRCS. And with the way we did this, many of our colleagues from other specialty started joining us, and now we are slowly delivering other training programs as well, like the FRCS vascular exam. We have a faculty to do PLAB training. We have faculty to start FRC Ophthal, so FRCS Ortho. So these are all the programs which is coming in, but our primary goal with which we started PrepMedico was to train candidates in the United Kingdom for FRCS general surgery exams. And when we did this, a few of your colleagues from Saudi saw our videos, and they felt that the training program and the mentorship program which we do for the FRCS training almost mimic the exam situation in the Saudi Council, and many candidates came to us asking us to train them, and we have been training candidates who are preparing for this interview in the Saudi for the last 3-4 years as an one-to-one basis, and we had excellent success rates. Based on the success in this program, we really thought that this is something which is very, very essential for the surgeons who are appearing for the consultant interview program in the Saudi, and hence we thought we will make a group and we will initiate a structured training program for these candidates. So that's the whole idea behind what happened. So in the next 2 hours, this will be the session agenda. So I will be very briefly telling about who we are. When I say who we are, what is PrepMedico, what we have been achieving in the field of surgical training, general surgical and the general surgical specialty training, and where we are marching towards. And then I will have our other faculty colleagues who will be talking about why should you choose KSA for your surgical career, how can you work in the KSA, and then in detail about the SCFHS consultant interview process, who are all eligible, how do you prepare, and what are the exam patterns and various pitfalls. And we will also discuss, once you clear these exams or the interview process, what is the next step before you go and start your career as a consultant in the Saudi. And then we are also planning to do a mock viva, something which is exactly similar to your actual Saudi interview process. Again, you might know that it's an online interview process where you have 2 scenarios. Each scenario will be discussed for 30 minutes. So we will try to do a 10-minute, taster kind of a viva for you to understand what is this viva and what kind of answers we expect. For that process, we will need some volunteers. So please be prepared to come and participate. But, this is very, very informal. And the whole aim is to, for you all to understand what is this mock and what is this viva and stuff. Okay. And at the end, we will have a question and answer session where you can ask questions. And if you have any questions in between, if you want to stop me, you can raise your hands and I can stop in between and talk to you. Also, if you want to put up your questions in the chat box, you can do. I can see someone has raised the hands. Do you have any questions, Digilal? Sorry. No? Someone has raised the hands? That's fine. Let's move on. Right. So who we are, as I told, 4-5 years back. Okay. So I got my complete surgical training, HPB and transplant training from India, and I moved to United Kingdom in 2018. And I did my first job at the Cambridge University, and then moved to London to the Royal Free, where I did HPB and transplant fellowship. Subsequently, from 2023, I am working as a consultant surgeon here. I gave my FRCS exams in 2020 in the United Kingdom, and what I found was there were a lot of gaps which we could fill to improve the success rate of the FRCS exams. If you see in the United Kingdom, there are 2 groups of people. One are the trainees who get trained here, and other one are the immigrants like us who moved from different country to the UK. And there was always a significant discrepancy in the success rate. The non-UK trainee candidates were, the success rate was just 20 to 30% when we started this program. At that point, we realized that, okay, there is something we can do in this area. So me, along with few of my colleagues, joined and we started a mentorship program rather than a course, where we travel very closely with the candidates, train them, identify their weakness, tell them what is essential for the candidates. Thereby, we have achieved significantly in the United Kingdom surgical training program. These are all my group of faculty colleagues in the United Kingdom, where we formed a group and started the FRCS program. And so far, we have conducted 9 courses for FRCS exams starting from 2021. And This is our success rate. So this is our national average in the United Kingdom. For a UK trainee, the pass rate is 88%. Ours is 83. However, our UK trainee participants are less. But the big difference is the next two lines. The non-UK trainee, meaning the people who had moved from outside the country to UK. Their success rate was 44%, but with our mentorship program, we had increased to 86%. This is the statistics of our last course. Similarly, the overall pass percentage on an average, combining both UK trainee and non-UK trainee, 70% is the national average, and we were able to achieve 85%. So this is what we were able to achieve in the FRCS program. And to the top of it, looking at how we prepare the candidates in the United Kingdom, our entire mentorship program is being accredited officially by the Royal College of Surgeons of Edinburgh. This is what we started to begin with, and then slowly our colleagues, so this is not something like a business motive program or a company which was established. This was purely established to help candidates who are in need. Okay, in the present world of everyone having busy schedule, it is very, very difficult to identify an appropriate person or a team or a platform to get trained. So we wanted to change it and make PrepMedico a platform where anyone who need, career guidance or training can approach us, and we will have some solution. So with this background, we have many of my friends and colleagues who joined us, and they started the FRCS vascular program, PLAB training program, FRC Ophthal. And how SCFHS came into PrepMedico was, as I told, all our videos and training programs are not all. There are few videos which are there in the YouTube and very many social platforms. And few of your present day consultants in Saudi, they saw these videos and they felt that this training program is exactly similar to the interview process which happens in the Saudi. And they approached us to train them. So we had trained so far 10 to 12 candidates as in one-to-one fashion, meaning they come to us and we join, and one candidate will be there. We will be training them, and they all felt very good, and they all cleared in their first attempt in a very happy and a very confident manner. So what we also do, so based on this, so this is how we do it. And eventually looking at how we could train this process, we had meeting with few other senior faculty in the Saudi, and we decided that why not we form a structured program for the Saudi interview process, exactly like how we do in the United Kingdom. And hence we framed whatever is the course which you would have known, or I will be talking later. And that is why we are here, where we will brief about what is this process and how we as a team could help you in succeeding this interview process in a confident manner. So apart from the, the online teaching, which is face-to-face, we have several methods of incorporating knowledge to our learners. One is the learning management system. In other words, a simple thing is an app. We have our own app, which is available in your Android device or Apple device, and which is also available as an app for your desktop, where you have all the essential study materials which is required for this exam. Second thing is, when you participate in the courses or whatever program you join with us, either it is one-to-one mentoring or as a course, all the contents will be recorded and it will be available for you in your hand for you to review anytime. So this is one way of teaching. And the other way is using a Telegram group. This is something like an FRCS group where we have separate, groups for each specialty, where apart from teaching, apart from what you have in the app, we will be asking you questions now and then to train you in a day-to-day basis. We will tell you, okay, how do you manage a patient presenting with right hypochondrial pain, but who is taking, oral anticoagulants? Then we will ask you to type, or you will ask you to dictate. And you are all aware that this exam in the Saudi is an exam which you need to do in English. And I'm pretty sure many of you may not have English as your first language. And one of our core principles or core objectives in this training program is to develop your language skills as well. Once you have the freedom to speak in the language you want, all your knowledge can flow easily, and that is one of our primary objectives. So as I told, as of now, we have been doing one-to-one mentoring, and we have a specific SCFHS library where you come in, where you have all the essential learning materials in the form of PDFs. And also we have some recorded videos on different specialties like general surgery, upper GI, endocrine, vascular, colorectal, etc., where you can just play those videos to understand. So in this way, you will be able to gain the knowledge and understand how this exam happens. What we are doing as a next step now is the course. So in this course, what we are planning to do is you as a group, we aim to take up to 10 participants per course. You will come, and this course will run over a period of 8 weeks. And every week we will join and we will train you in individual branches within the general surgery. And we have an excellent faculty members at this moment, and we have few more faculty who will be joining. So I have introduced myself. I am in the UK. I have not done the Saudi exams by myself. However, I have trained several candidates for the Saudi exam. But we have very senior colleagues like Dr. Adil, who is a very senior consultant and also an IELTS instructor. And we have Chaib. Again, he is one of my faculty colleague, as well as I trained him a few years back before he became a consultant, and the backbone of this entire program, who tried to gather people and trying to coordinate with all the faculty, and he will be the point of contact and in charge for the entire program in this SCFHS. And we have Dr. Tuki. Again, he is a well-renowned faculty member in Saudi and also an SCFHS examiner. And we have Professor Ehab. He is again a consultant at Saudi, and I had personally mentored him for his FRCS exams, which we cleared recently. So this is our faculty group at the moment, but we will be gathering more faculty as we move on. So with this background, what I'm going to tell is I'm going to give means I will be moderating the session from now on, and I would request my other faculty colleagues to give a talk on important topics, these things. Why should you choose KSA? Second thing is, how can you work in KSA? Third thing, how it looks, means how is the actual exam, like this is the mock exam which I talk about. We will give some exams, and then what is the solution for you all to train in a structured manner, gain the communication skills, and appear this exam in a confident way and clear the exam in the first attempt. So this is what we'll be discussing, and I will hand it over to Dr. Adil, who will be continuing from here. Dr. Adil, what I'm going to do is stop sharing my presentation, so you can present from your side. Yeah, you can unmute yourself, sir. You are muted, sir.
Hello, assalamu alaikum.
Wa alaikum assalam.
My name is Adil Mahjoub. I'm a consultant general and laparoscopic surgeon. I'm an ATLS course director. I was fully trained in UK, but that was a very long time ago. I did my registrar and senior registrar training in UK. I finished my training in 1999. Then I joined Saudi Arabia. First of all, I will just give a brief about the how can you be accredited as consultant in Saudi Arabia. In our early days, They used to get this through a panel of consultants who comes to UK. For me, for example, my interview was carried in Harley Street by 2 senior consultants in surgery. That would be the end of your accreditation to work as a consultant in Saudi Arabia. And that is before even the era of Saudi Council. So it's long time ago. Then this went into an exam for consultants, and this took about 5 to 6 years. Then they changed into this new modality of the 2 interview cases. So this is about overall the way have the revolutionization of accreditation of surgeon to work in Saudi Arabia. I will give also a brief about the systems in Saudi Arabia. Ministry of Health is the largest employer in Saudi Arabia. In Ministry of Health itself, the system have been developing since the introduction of 2030 vision by Prince Mohammed bin Salman. The system now changed into more or less like in UK, where national health system work as separate authorities. Now there is what we call the clusters. And the cluster is actually like the health authority in UK. It's a group of hospitals in the region. Each region have got its own cluster. The cluster will be running the whole number of hospitals in that region. It got its own budgets. It got its own autonomy to recruit consultant surgeons from all over the world. And even they got their own authority to identify the salary scale for consultants and their needs. And this makes life now even far more easier. If you have passed this exam, then the chance that you will get a job in Kingdom of Saudi Arabia is going to be easier. Why? Because these clusters now are supposed to be an autonomous regions. In the past, it's always been that the health system in Saudi Arabia run as primary health care, secondary care hospitals, and then tertiary care hospitals. Even now, within the cluster, some of the hospitals are going to be converted into tertiary care hospital or tertiary care units. So getting recruited into this cluster is going to be even easier because this cluster is going to be autonomous, self-running. So if anybody wants to ask anything about how the system in Ministry of Health run, he can ask me any question.
Rather, can you share the presentation, please? Dr. Adel, can you share the presentation, please?
This presentation is
Not working.
is not written.
I will open. Don't worry.
Thank you.
I will share it. I'll share it.
Perfect. Thank you.
That's fine. Can you see? Abe, can you see the presentation?
Yes, I can see the presentation.
Yeah. So, Chaib, are you continuing to present or?
I mean, I can present this, but I just want to give the people a whole idea about
Absolutely.
How
Absolutely,
the system run in Saudi Arabia, what is the systems, and so why should we choose Saudi Arabia? Now we can come to the thought. Saudi Arabia have got a very good and well-developed medical services, and if you got the chance to work in Saudi Arabia, it is a very lucrative jobs and give you a very competitive salaries and a tax-free income. Of course, now there is a 15% tax for anything in Saudi Arabia, but the salaries are not yet taxed. So this is a very good advances that even everything is being taxed, the salaries are not taxed in Saudi Arabia. So you are still getting a whole your salary tax-free. To develop your career in Saudi Arabia is very easy. You can even change from one hospital to another, or you can even change from one cluster to another, as far as you want to change your position in Saudi Arabia. And I have to say that the quality of life in Saudi Arabia have been changing in the last 5 years. The quality of life in Saudi Arabia have changed over the last 5 years dramatically. There is a lot of freedom in Saudi Arabia about what you want to live and how you want to live. Of course, for Muslims, they got the 2 holy places where you can do your Umrah, you can do your Hajj, and you can do what you want. A lot of entertainment areas other than these areas in the whole of Saudi Arabia. Next. One of the, it's, as I said, even in the remote areas, it's a high standard of healthcare system, one of the best quality care system in the world. And most of the Saudi hospitals are actually either what we call Sibahi accredited, GCI accredited, or other accreditation system. So you are going to be working in a hospital where there is a full accreditation. So even if you want to move from Saudi Arabia into another place in the world, it is all hospitals in Saudi Arabia. Nowhere, even in remote areas, they are all fully accredited. Of course, Saudi Arabia provide financial security and economic growth and stability. You can, if you work in Saudi Arabia, you will not find any difficulty to access any sort of advances in surgical technology. Take example of ours, me and Shia. We are working in a hospital now where we got, the hospital is fully digitalized, so that even if you want to access the your radiology, you want to the reports, you know, the X-rays itself, you can just access them through the HIS system. The thing is that the hospitals are very well disciplined, that if you work in a department, the department have got a head. The head of this department is under the umbrella of the medical director. The medical director is under the umbrella of the hospital director, and all hospitals are under the umbrella of the cluster. So working is very much disciplined, and that attending time, leaving time of the hospital, getting your salary, is you get your salary every month, is getting into your account, getting your bonuses, getting your vacations organized. You can organize your diary for 1, 2, 3 years. There is no problem. You can even organize what time of the year you can go into your vacation without any problems. We come to a very important point. In the past, Saudi system used not to have an insurance. Now there is an insurance where the insurance company is going to be covering you from litigation. And if you got a case, then in the past, you used to be pinned into the hospital where you are staying. But now, because of this insurance system, you can easily get what we call a letter from the insurance company, and then you can travel abroad, or even you can leave Saudi Arabia. And the insurance now is mandatory, that everybody working from a nurse down to a consultants have to be insured. So with the introduction of the insurance system, the old vision or the old view of Saudi Arabia have been a place where you can be hooked. This is no longer valid. Now you can easily get your insurance covering you for all the litigations that you, inshallah, you will not have any litigations, but that should not be a worrying point at all. Now the insurance will cover everybody working in the health authorities. Next. I think in all hospital, we got all the layout that follows the international system of accreditation. That is to say, the hospital have got a mortality review, have got a morbidity review, have got accreditation body that says that what you should do and what you should not do. They will guide you into a very good path when you come to write in fact, every hospital have got a precise committee that says what you should be doing and what you should not be doing. This is what we call the committees. So you should not find any problem regarding that respect. All hospitals in Saudi Arabia are accredited either by SCFHS or even more than SCFHS. As I said, Ministry of Health actually run more than 300 hospitals. Even Ministry of Health itself have got tertiary referral and what we call medical cities. Medical cities are found in each region in Saudi Arabia. This is where if you are stuck with a very difficult case, you can easily transfer cases from the hospital where you work into these places. I will give just a simple example. Me and Shia were working on a hospital where we got a little problem with ERCP. We never stuck with any patient having either an emergency or even a life-saving ERCP. If you got a patient with severe cholangitis and you got a stone, and that you can easily write a what we call life-saving fax, this patient will be immediately transferred to one of the good facilities where the patient is going to be managed properly. So the fact that you are going to stuck with a case over your capability, or you are going to hang on with a problem, that is no longer a case. The second biggest employer in Saudi Arabia is private sector. Of course, next to the private sector is the armed forces, and next to armed forces is the National Guard, and next to National Guard is going to be security force. But definitely the second biggest employer is the private sector. Even though any private hospital, no matter how small it is, even if it's only 100 beds, it have to be accredited by all the accreditation bodies. So no hospital is allowed to work in Saudi Arabia without being fully accredited. And all hospitals have got all the technologies that need for the, what I say, evidence-based management of any patients. That what you need to do is you just need to PIP in. The system in Saudi Arabia runs Saudi Commission for Health. Actually, I think it started about 20 years ago. And it went into a lot of modalities. But these boys are actually running a very good job. Now they got a very organized system of whom to accredit at certain level. Accreditation in the hospital is GBs or junior staff, specialists, and then consultants. Each class have got its own license. Each class of consultant have got its own subdivisions. Like we got general surgery, we got upper GIT surgery, we got colorectal, vascular, and other specialties. Of course, to renew your certificates, you have to have your CME hours. CME hours are not difficult to get. You can easily get them by participating in meetings and in conferences. I think to get into to get your Saudi Council acceptance, you really you go through a lot of verifications. But this verification is for your good and for the Saudi Council itself. So all your papers, including your experience certificates, are going to be validated through the well-known international validation system. Not only that, but when you are being accepted to the hospital, the HR of the hospital is going to do what we call third-party review, so that they got the chance to ask your current hospital about your job in that hospital, about your logbook in that hospital, about everything you have been doing. So the accreditation process goes through a very well known tract. It's a simple tract. As I said, Saudi Arabia have got medical cities, tertiary referral hospitals, secondary level, and primary health care. There are so many well advanced. I think Faisal Specialist Hospital is being rated about the 13th or 14th hospital in the world 2 weeks ago. Most of the medical cities are ranked within the fairest 100 hospital in the world in the last review. King Abdulaziz in Jeddah, I think it's about 27th. National Guard Hospital, 98. I cannot remember the figure, but these are well advanced medical centers. In our hospital, in our ICU, we got a telemedicine, and even if we got a difficult case that we need to discuss with one of these medical cities, or we want to discuss in one of the tertiary referral hospital, we can easily discuss the case through telemedicine. So digital healthcare system in Saudi Arabia is very advanced, and I have to say, maybe one of the best in the world. I mean, even your attendance to hospital is digitalized. Most of the hospital now are paperless hospital, that you really need just to be on the your computer to do all your data. Your clinics are digitalized. Everything is being digitalized. As I said, Vision 2030 have modernized Saudi Arabia remarkably. The life in Saudi Arabia is now a very enjoyable life. In most of the Kingdom of Saudi Arabia cities, the life is really well modernized. I don't think there is a big difference in the life in one of the big cities in Saudi Arabia from any city anywhere in the world.
So I think I will take the...
Okay, thank you very much.
Thank you, Dr. Adel. Thank you very much, Dr. Adel. So my name is Dr. Faisal Shabdor. I'm Algerian, former assistant professor in Algiers, and I'm general surgery consultant in Saudi Arabia. Thank you very much for joining us today, and pleased to be between our prestige faculty, Dr. Manikandan, Dr. Adel, and all the other faculties. So the chapter that I will discuss with you about is why should we choose Saudi Arabia? What is the opportunity that we have here? As Dr. Adel said before, this is one of the most developed healthcare system in the Middle East, and one in the most advanced healthcare system in the world. So now the level of competition is with the tertiary hospital to have the accreditation from worldwide known organism. We are speaking about competition at the level with the US, Canada, Europe. So the standards in the minimum standards worldwide is been already in his way and work with.
Sorry, Chaib. Let me just represent the slides. It just went off. Just a minute, okay? Let me just put it, okay? So because this is the, sorry about that. Let me put again. Okay. Don't share your screen. Why? Sorry, just a minute. Something.
Can I
Okay.
try?
Okay, let me stop sharing. Something went off. If you can try, that will be good.
Okay.
Yeah, I have stopped sharing. Yeah.
Screen. Share.
Can you?
I don't think so.
Wait. Let me try again. Just a minute. Yeah, it should come. I don't understand why it should not. Yes, it's coming now. Okay, let me put the slideshow now. Yeah.
No, it's working.
Yeah, fine. You can start presenting. I'll change the slides for you.
Perfect. So our second question is how can we work here in Saudi Arabia? So the first thing to know is about the Saudi Commission for Health Specialty. This is the most important organism organizing the health system in Saudi Arabia to give the overseas licensing, certification. He is the one to guide the professional development in the healthcare sector. He is the one regulating the healthcare professional and the healthcare by law. He is the one to ensure high standards in medical practice. How is this is possible? By doing the verification, examination, and continuous training for all the medical staff alongside the Saudi Arabia. So implementing the licensing exam for consultant and specialist, as Dr. Adil said, was recently in the last years one of the fundamental to normalize and standardize the quality of medical care here in Saudi Arabia. Next, please. Who is eligible for the exam? So any doctor who has a recognized medical degree with specialty board from his country, a minimum of clinical experience years, a minimum of 5 years for the consultant, and less than 5 years, he will be classified automatically as specialist. A verification reference number, which is done by the data flow group. The idea is verify authentify the diploma and the subscription for the medical council in each country. For example, in Algeria, it's known as Conseil de l'Ordre. Here, this equivalence in the Saudi Commission. So you need to have a valid license to practice. You need to have a valid license for practicing, and sometimes they are demanding certificate of good standing. Your job certificate should be updated at least for the last 6 months. That means you are on exercise. And after having all of that, you need to register through the website, which is Mumaris Plus, which is the official website of the Saudi Commission. Submit all the documents necessary, and after a few days, you will have a reply if your request is accepted, or you still have some documents to complete or to verify through this data flow system, or sometimes if there is issues with certificates, you need to have everything very clear. Once you have the acceptance through this your account of Mumaris Plus, you will get to have the right pay the fees, and you will have the date of your examination. For the consultant, next please. For the consultant, the exam will be an interview. We will discuss the details just after. And for the specialist, it will be a prometric exam by MCQs. So why they are making this exam as mandatory to have access and work in Saudi Arabia? This to ensure a standardization in the medical knowledge, the clinical practice, maintaining high healthcare standards in Saudi Arabia, which is very important. Maintain a level of standard and to get these accreditations known worldwide, it's not easy. So everyone who need to get into the system need to pass through this process. So any doctor, he will be evaluated about his clinical expertise, the decision making, his safety in the system. As Dr. Adil said, for example, one of the prestigious programs is the referral system, and it is working not as every hospital in each self, but as a whole system. That means if you don't have service, this service will be available. This service will be available in the secondary, in the medical cities, in higher centers, university hospitals, and the way and the path of the communications inside the system is very easy, through the fax, through discussions directly with consultants, or through the life-saving system by direct call to the ministry. And for the life-saving cases, you can even have evacuation by airplane if needed. So to maintain this quality of healthcare and to improve this assessment about the clinical expertise, decision-making, the safety, and the professionalism is mandatory before going into. So ensure the high quality of healthcare delivery is one of the vision of the 2030 and one of the purposes to develop this system. Next, please. So for the general surgery consultant exam interview, it will be in 2 sessions, each one in almost 30 minutes. Strict condition through Zoom. Before coronavirus pandemic, it was in presential, but just after they convert to Zoom sessions, and still until now through Zoom sessions. So very strict condition, almost 4 to 6 clinical cases by session in different specialty, colorectal, upper GI, breast, endocrine. It will cover the whole program through interview direct, question, answer, and assessment. The language used is English. So this is for the exam. Next, please. How can we prepare this exam? So it will require a good level of English, a good knowledge-based learning. That means we should be up to date with the standard of care, a clinical training aligned with the standards and the guidelines of the Saudi Commission for General Surgery path, and an active training for the exam. We need to respect the time. We need to give the keywords. We need to speak well, to be fast, to have a good decision making, and very important to be safe. As I said, they are here working as a system, and the safety is number one. It's mandatory. It's not about you know or you don't know. You have some privileges. You need to respect your privileges, and you need to be safe for the patient. This is extremely important because the results by the end are very important to success, and everything is monitored. And as Dr. Adil said before, there is a lot of committees in each hospital which following all the statistics, all the data about the admissions, the morbidity, the mortality. Any case of misbehavior will be discussed through the committees and decisions will be taken. So all of that need to be known. Next, please. What will you have after the exam? You passed the exam, you cleared it, so you will be certified. So successful candidates, he will receive his certification from the Saudi Commission, which allowing him to work through Saudi Arabia, whether public hospitals, private hospitals, and now as the up-to-date now, which will be fully in work in 2027, the medical health clusters in every region. So an excellent job opportunities, and with a possibility of discussion on the salaries. You will have the work permit. You will have, very important, you will have the right to activate your malpractice insurance, because what you need to know, without having the certificate, your malpractice insurance is not activated. So once getting this certificate, that means you are fully working legally, comfortably. You have the right for the renewal of the contract. You have the right for the professional progression, and it is so colorful in your CV as you have foreign certificate from the Middle East. And as we talked about before, if you have, for example, a hospital like King Faisal Specialist Hospital, who is ranking with the top 20 hospitals in the world, that means give an idea about the quality of care in all the Saudi Arabia. Next, please. So now we will pass to how it looks like a real life exam. We will do some viva taster, and we will begin with Dr. Adel, as he is ATLS course director. Dr. Adel.
So thank you, Chaib and Adil, for such a clear description and about the exams. So as Chaib told, let's move on to taster viva sessions. So we are planning to do 3 or 4 scenarios, and each scenario would be around 10 minutes. So we want volunteers. So who wants to go first? You can raise your hands and join. Just volunteer. It is not something to test your knowledge and give you feedback and stuff. It's mainly for, to have a taste of how this viva would be, what kind of and what depth of questions they would be asked. Anyone would like to volunteer? Among 20 people here? No one?
Maybe we can just run the whole thing as a scenario. Let us just run the whole thing as a scenario first time.
Yeah.
So we just give the people an idea about how things goes.
Yeah.
Let us take. Can I start?
Yes, sir. You can.
Say that you've been in the interview given the case of a 23-year-old male patient brought to emergency department by the emergency medicine people due to road traffic accidents. So what you'd expect that the first question that you are going to be asked is, how would you approach this patient?
We would like to have your answers.
You can tell us how he would approach this patient.
It's not an exam. It is just
not an exam. It's just
to show you how things are going during your exam. So no good or bad answers. We are just discussing, show you how it's going. So anyone can unmute himself and give his answer.
What is expected from you is that you say that I'm going to follow ATLS protocols, because ATLS is definitely mandatory for any surgeon, ER, physician, and everybody who's working in a surgical department in UK, in Saudi Arabia. So your answer should say that I'm just going to follow ATLS protocol. All hospitals in Saudi Arabia have got their ER tagged to it is ATLS protocols for management of trauma cases. So you say that I will approach patient first airway and make sure that the patient have got his collar. I will just approach this patient and ask him if the patient is been talking, then this means that the patient is conscious. I will assess the patient conscious very quickly. If the patient is talking, this means that his airway is going to be patent, and that I will move to B. Then B means that the patient should be on oxygen. So if the patient is not intubated, the patient should be on oxygen mask. And at this time, my patient should be on a monitor that I need to make sure that his oxygen saturation is more than 94%. Then I will move to C. Where is the patient's? I'm just going to identify the patient blood pressure. By this time, the patient should have been identified what his blood pressure is. And if he give you the scenario that this patient now blood pressure is 87/56, how would you move from this point further? Any candidates? Anybody would answer? By this time, he gave you the scenario.
There is Dr.
Mohammed is there, yes. Yes, Mohammed, you can answer.
Yes, at this time, I would ensure that the patient is getting a 2 wide bore cannulas and try to give him IV fluid to raise his blood pressure.
Okay. This patient blood pressure is 87/56. You put 2 cannulas, you start taking all the necessary blood. What adjuncts are you going to be requesting at this time?
I would first I would make sure that he's not having any bleeding from anywhere, and then I would take the necessary blood investigations, the CBC, the urea and electrolytes, and these investigations.
Which part of his body that you are going to be worried about, and what adjuncts are you going to request?
His chest and abdomen.
Okay, good. What adjuncts are you going to request?
I would request a fast scan and chest X-ray.
That's exactly. So it's a standard here. Any patient who's a trauma patient, even if the patient is not, his blood pressure is not low, fast is mandatory part of the trauma management in Saudi Arabia. So you should request a fast that is going to give you a good idea why this patient is hypotensive. So now he might just ask you what further things that you need to do to this patient.
Regarding the next step, I would make sure that the first and the primary survey is complete, and then
you stated that the fast is. Then you need to know the result of the fast. This patient, yes, this patient fast said that there is a large amount of free fluid in the abdomen. Patient is still hypotensive. What will be your next move to manage this patient?
Okay, I would make sure that he's receiving his IV fluids. I would request for blood cross-matching, and I would take him to the OR.
That's good. So then now the decision is that this patient need to go to OR because patient have been receiving fluids, and with fluid he received blood. Then this patient next movement is going to be the patient is going to go for OR. What will you do intraoperatively? What are you going to do when this patient now is inside the OR?
Okay, my patient is in the OR now. He's anesthetized right now. I would prep and drape him, and I would immediately go for laparotomy. I would open his abdomen, and I would look for potential sites of bleeding. Firstly,
anything that you are going to verify before you put your knife on the skin?
I didn't get you.
Yes. As we said, we follow strict rules.
Okay.
Let me give you this hint.
Okay.
Any patient in hospital, before we put the knife on the skin, we do timeout. We must make sure that we confirm the patient, we confirm the procedure, we ensure that all the equipments needed to complete this procedure safely are available, that the anesthetist is happy, that the amount of the blood that might be required for this procedure is also available in OT before we start the knife on the skin.
Okay.
Okay. So, good. Can you proceed?
Okay. I would start my procedure, opening the abdomen, and I would immediately go to look for potential sites for such a bleeding. I would start with the liver and the spleen first. Then I would look for other sites.
Do you have any concern about the patient before you put your knife? This patient, when you open the patient, are you going to give the anesthetist any hints what he needs to be prepared for before they start the knife?
Yes, I would ask the anesthetist to be prepared to transfuse blood immediately when I open the abdomen.
The patient might collapse
Bleed
after
profusely.
opening.
Yes,
That's
yes.
good. So you will warn the anesthetist that before starting the knife, that he should be prepared, his blood should be prepared, and he should be ready to resuscitate the patients. Okay?
Yes.
Intraoperative finding that there is a ruptured spleen. How would you proceed?
Okay. I found the ruptured spleen. I would try immediately to control the splenic artery and vein, the splenic hilum, if it's readily accessible. If it is not, I would try to pack the area and suck the blood inside the abdomen to clear my vision, and then I would go to control the splenic vessels in the hilum.
Would you pack the 4-quadrant before you start looking for the site of the bleeding, or would you not prefer that?
Yes, that I would start before trying to identify the source of the bleeding.
Exactly. Before you start to identify the source, you better pack your 4-quadrant, and then you start depacking them one by one. Okay. Okay. Few days later, there is a persistent leak from the drain. How would you proceed for this patient's management?
Excuse me, I didn't get the question.
Now the patient's that surgery finished, you did
Okay.
your splenectomy, you put your drains, and the patient was transferred to ICU. 3 to 4 days later, you notice that there is a persistent leak through the drain.
Okay.
Right. How would you proceed to manage these patients with these findings?
I would suspect a coagulopathy in this patient. So I would try to get CBC and coagulation profile.
Okay.
To see if this patient is having a DIC or anything. I would calculate his DIC score.
It's better to send the leak.
This is a leak. This is not a block. How would you proceed managing your patient?
Yes, Dr. Shamsu.
Yes, Dr. Shamsuddin from Algeria. it's better to send this leak to analysis. It may be pancreatic leak.
Good.
And good CBC and chemistry, amylase, and lipase.
You send the patient's fluid for analysis, and it showed that there
Analysis.
is a large. This is actually amylase is more than 3 times normal.
This is confirmatory for pancreatic leak. Need to do an ERCP or MRCP to detect it is high leak, high output, or minor output leak. Minor leak will take some days and will be managed non-operatively.
Okay, so this is how your interview goes if you've been given a case. Now I will push the ball back to the boss.
Yeah, so whoever has volunteered, you did very well. So if you see, just to reflect on this scenario, this is a very typical and a common scenario any general surgeon who offers emergency general surgery service would get day in and day out. Okay, so few important things which I want to tell as a take-home message from this simple scenario and what is expected in this exam is, see, we all know, okay, this patient, a trauma patient comes here, we all have an, things running in our mind or thoughts running in our mind, okay, what all could be wrong in this patient, what you should do. Everyone will know that, okay, patient, if patient is not breathing, we need to put in a tube. Patient needs a line, blood has to be arranged, a scan has to be done, surgery has to be done. Everyone knows that. But what is required in making a safe decision and not to miss anything is a systematic approach. Yeah. So that is where in a trauma, the ATLS systematic approach comes in, where you go step by step, A, B, C, D. And until A is sorted, you don't go to B. Until B is sorted, you don't go into C. It's mainly because if some problem, so if you go there, you see a patient, say, who's profusely bleeding from the leg. If you go and press the leg and stop the bleeding, although that is more, dramatic for us in that scene. And if the patient is not breathing, this bleeding is not going to kill this patient, but the breathing is going to kill the patient first. So that's why we have this systematic approach. And this systematic approach is very, very essential for everything, not just the ATLS, any critically unwell patient, any patient who has come to your clinic coming and sitting in front of you, or any patient whom you had operated now becoming unwell. So approaching in a systematic fashion and expressing how you approach in a systematic fashion is very, very ideal and basic thing in this exam. Okay. And
Absolutely.
Also expressing your thought process clearly. I know that both of you know what you are doing, but you did, struggled a bit when you want to verbalize what is your thought, so that is the second important thing, which is very essential to succeed in this exam. So thank you, Adel, for this. And with this background, let us move on to another scenario. Probably Chaib, you can do it.
Yes,
Yeah,
I will. Yes.
who wants to volunteer now, guys? It's good that people are volunteering. Anyone who wants to volunteer, raise your hands. Just volunteer, don't worry. If you don't know, we will go to the next person. Anyone else apart from Mohammed? If no one, I'll go with. So why don't Shamso, you want to try, Shamso? You were doing very well. Okay, let me move with Shamso, and then half will be Yasid. So let's start with Shamso.
Okay.
Yes.
So you are in the clinic and you will have 25 years old female patient to your OPD, outpatient department clinic. So the patient will come for breast lump for 1 month duration. How will you approach the patient?
20 age, please.
25 years old with history of breast lump for 1 month. And she came complaining for that. How will you approach the patient?
First, we'll start with this onset, how this lamp starting growth since how many time, and with starting and the personal history of any breast lamps, other breast lamps, or family history of cancer or anything. After we will go to the examination of this lamp, its mobile, hard, skin change, and nipple discharge. This and the size of this lamp. This is part of this triple assessment of any breast mass. After we go to the ultrasound.
No, we will go step by step. I will give you the data. So you did your triple assessment, which is very good, of this patient. You have breast lump for 1 month. So she discovered it during her shower. No change in the size. The patient is single. She has her menarche at the age of 15 years. No history of trauma, no history of weight loss, decrease of appetite, no history of fever, sweating, no history of radiation exposure, no personal or family history of cancer, breast cancer, just allergic to egg, and she's a smoker. On examination, patient looks well. She's obese lady, well colored. So both breasts are symmetrical, no obvious mass, tethering, skin erythema, nipple and areola complex looks normal. And we have a palpable, well-defined right breast mass at 3 o'clock, 2 by 2 centimeter. The other breast is free. So what will be your next step?
The next step is ultrasound.
Okay, you did ultrasound breast and it showed you well-defined hypoechoic solid mass as has a diameter of 20 by 18 millimeter. So based on the results,
how many size, please?
20 by 18 millimeter. So based on the results of the radiologic investigations, what should be your plan of the management? And what is missing in the ultrasound report?
This is most likely fibroadenoma. There is no. This is it's not high risk.
What is missing? What is missing in this report? Is it complete report?
Missing?
Yes.
Lymph node also. You need lymph node, axillary lymph node. Also. Size and hypoechogen.
Which score we use to score this kind of lesions?
This BRATS score.
So
yes.
you should be sure it is. If you are suggesting it is benign looking lesion, fibroadenoma, you should be sure in the description of the radiologist it's virus 2 at least.
You must request this at the interview.
You should. Yes, you should give your opinion. So this patient most likely has fibroadenoma, which at that time requires no treatment, just observation. What are the indication of surgical excision of such lesion?
If it is big, more than 2 centimeters, or there is a rapid growth, or there is cosmetic discharge, need by patient excision.
Okay. So this patient came to your clinic 6 months after with increase in the size of her breast lump. It became double. What will be your decision? How will you approach this type?
This will be need surgery excision. Need excision.
So straightforward surgery. You did the surgery and you are on carcinoma in situ or ductal carcinoma. Is it safe what you did?
Can you repeat, please? I don't.
You did the excision, and it showed that there is ductal carcinoma. Did you miss anything in your approach?
Core needle biopsy.
So you gave us, as we are discussing in this webinar, you gave a keyword in the first question, triple assessment. Whenever you have breast or update about breast, you need to do triple assessment. This is a key: history, clinical examination, imaging, and biopsy if needed. So you need to approach the patient as a new one, because you have a history of breast lump and it increases in size within 6 months. So you need to do take a history again, examine your patient, check the other breast, check if there is other masses, check if there is axillary lymph node, search of any new signs, constitutional signs, then go for ultrasound. If suspicious, you need to have to do trocat biopsy. Then other time we will discuss according to the results of your triple assessment, we will decide. But go straight forward to do excision, so you will be in trouble. It is not safe. Okay, so further assessment confirms the diagnosis fibroadenoma. The size now is 30 by 29 millimeter. How will you prepare for her operation? What are the steps? You have this patient, you did your triple assessment, you confirm the diagnosis, you have this fibroadenoma, 30 by 29 millimeter, and you indicate to do the excision. You will plan your patient for surgery. How will you prepare, and what are the steps?
First, it is consent and DVT prophylaxis, and inform the patient of the complication and ulcer, PPI from ulcer.
What
and
else?
time out. خلاص.
So
site marking. Site marking.
So you won't request labs. You won't check your CBC and coagulation profile.
We'll see.
You won't order for your OT list. You didn't speak about the prophylactic antibiotic. Is it indicated or no? And the consent, is it consent or informed consent? So which type of admission should you will admit the patient for 2 days, or you will just do it as day case? Which type of admission?
Day case. It's day case.
Okay, so you will plan your patient as day case under local or general anesthesia.
Local anesthesia.
Okay, local possible general anesthesia. Consent or informed consent? And what's the difference?
I don't know.
So the informed consent, you need to explain to the patient with details about your procedure and the possible complications, and all of that should be written in both English and Arabic, and the patient should sign, and you should have a witness, the nurse with you in OPD. This is medico-legally. And if you will have any issue with the patient out of you didn't write, you will be in trouble. So this is the idea. It's very important. As we said, there is a standard of work that we need to apply. So the patient, I said the patient is smoker. So will you plan the patient for now, within 1 week, or what is the ideal time for smoker patient? Let's say chronic heavier smoker.
It's better in 2 months, I think. 2 months for the patient.
It can be 1 month. Okay. And did you inform the patient that she should be fasting?
Yeah, fasting. Yeah.
8 hours, because you can convert at any time for general anesthesia if the patient wants to explain. And no need for a prophylactic antibiotic. For the IPP, for the post-op, major surgeries, not for benign condition, I think no need. And as you said, good surgical site marking. This is once in OT. Okay, next question. What are the possible complications? You did these surgeries, and and what will you expect to follow in your post-op?
Complication is infection, hematoma, and lately recurrence, maybe recurrence.
Okay. And what about the general complications?
General complication is DVT, PE, and urine infection, and phlebitis.
Pulmonary infection.
Pulmonary.
Okay. Okay. How will you follow this patient in your clinic?
First, start by review the histopathology report and examine the wound.
Okay.
And this is it.
In fact, you have here two steps. You did your surgery. You need to decide whether give antibiotic or no. Basically, it is a clean surgery, no need. You have to give analgesia, instruct the patient about the wound care, and give him an appointment in your clinic. This is basic. Then, once in your clinic, you need to see the patient, examine the wound, collect the histopathology report, and once you have the results, you can decide what is the next step for the patient. Close follow-up or discharge from the clinic for benign looking condition, or it can be seen 6 months after, or if any issue, you can discuss the case in MDT. Thank you.
Okay, thank you. Thank you.
Samsa, you did good actually for your first attempt, yeah. And thanks for volunteering. Again, this is another typical example of an elective patient coming to your clinic with a breast lump. So if you had gone back to the scenario, you would know how the clinical knowledge is very, very vital. You know, for every symptomatology we face in general surgery, we need to know you need to have the common differential diagnosis for that patient that comes with your background knowledge or the actual knowledge. You need to know the basic standard evaluation pattern or guidelines, which is again very essential when it comes to the breast. You need to have a sequence of examination. How do you examine the axilla? What is triple assessment? When do you choose what? How do you choose? Again, you need to imagine that it is you who are sitting there rather than in this exam thinking that there's an examiner who is questioning you. If you always assume an examiner who is questioning you, you will lose your flow of answers. So just think that patient is sitting in front of you. You are the only person responsible for this patient. What all you will do in a safe manner. So that's what we are trying to test. And you did well. Again, you need to look into holistically. Although Chaib started in a way that this is a breast lump and you will be discussing wholly on the breast lump, he went into different aspects about, okay, smoking patients, what will you do? How do you consent this patient? What is a consent? What is an informed consent? And then patient comes back. Then he also discussed about wound infection. Then he gave a scenario where it could have turned out to be a cancer. Although it was to start with as a fibroadenoma, then came back with a big size. Again, you need to be worried there. A fibroadenoma normally is not expected to grow in 6 months. If it is growing, again, you need to have that's called as the higher order thinking. You should have a higher order thinking and not just a binocular vision of just sticking to it is fibroadenoma. It could be anything else. It could be a hematoma again. It could be a fat necrosis, or it's a new cancer which is arranged. So you need to start the process again. Or else, if you thought that it's a fibroadenoma only, and if you've gone in, made an incision, taken out, you would have converted, say, if it was a cancer, you would have changed a stage 1 or a stage 2 cancer to a stage 4 cancer, okay, which was iatrogenic. So these are the things again, which again stresses the importance of having a strong knowledge, having a systematic approach, and knowing the whole, holistic pathway of how you manage a surgical patient is very essential. Good, thank you, Chair. That was a good scenario. So who wants to go next? So I will do one scenario. Someone volunteered before. Who is that?
I think Dr. Taifour.
No, there was one more person who volunteered. Okay, fine. Let me go with Hajj. Yeah? Hajj, are you there? Oops. Where is Hajj? He brought his hands down. Yes, Hajj. Hajj Ada. Are you ready?
Can you unmute yourself?
Yes,
Yes. Where are you from, Hajj? Where do you practice now?
I'm from like Dr. Shahid, Algeria.
Okay, perfect. Okay, so imagine, Hajj, you are doing your general surgery on call, and you are getting a 45-year-old patient who has come to A&E with history of 2 days history of right hypochondrial pain and fever. The A&E doctors are calling you. How will you approach the situation?
I will approach this patient by taking history and physical examination.
So what specific? So before you go into the history, a patient who is coming to A&E, okay, with right hypochondrial pain and fever, what are all your differential diagnoses? Without even seeing the patient.
There is many differential diagnostics as heat cholestasis, cholangitis, if have fever.
What else?
Peptic ulcer disease, evaporated peptic ulcer disease, and pancreatic acute pancreatitis.
Excellent, good. So tell me what all history you will take from the patient.
I will I will ask him about when it started and site, irradiation, aggravating and relieving factors, associated symptom as fever, jaundice, vomiting, nausea.
Fine. So this patient tells that patient was absolutely fine until 3-4 days back. Okay. And pain started 2 days back, which was more in the epigastric region, and it has now moved to the right upper quadrant, and pain is constant. And for the last 24 hours, patient is also having fever. This is the history. What next?
Pain, fever, and he has a jaundice.
Patient is not aware if he has jaundice or not. What questions you can ask?
If has urine, bile stool,
okay,
sclera, I will ask examine.
Patient doesn't have that history at the moment.
Yes.
What next?
Okay, I will continue history. Constitutional symptom as anorexia, night sweating, family, person, previous medical and previous surgical history.
So anything, so in this case, given that you suspect it could be an acute cholecystitis, what previous history you will get the patient which might think that, oh, this is acute cholecystitis? What all you will ask?
History, if he has ultrasound, previous ultrasound.
Symptom wise, what symptoms patient would have had before?
Right upper quadrant pain, irradiated to back.
What else? What are the common symptoms of a patient with gallstones? What all they can present with commonly?
Right upper quadrant pain, fever, jaundice.
So this is all in a very severe form. What is the most common presentations?
Right upper quadrant tenderness.
Pain. Okay, what else? Pain, then?
Fever.
No, anything else? Say if a patient comes to you with, bloating and heartburn, can that be because of gallstones?
Yeah, I don't understand. I don't hear you.
No, if a patient comes to your clinic and tells you that I am suffering from bloating sensation, recurrent burping, heartburn, okay, and decreased appetite, can this all be a symptom of a stone in the gallbladder?
Yes, it's.
What is it called? What all these symptoms collectively called?
I don't know.
Dyspepsia. Yeah, patient can have dyspepsia. Can you describe what is the character of pain in a patient with gallstone? How does they normally present?
Been irradiated to back, aggravating factor, fat meal.
No, my question is, typically, when will this pain start? Is it after food, before food? How long after food? When it will settle? And what is this pain called in total? Okay, what is meant by biliary colic? How do you define biliary colic?
Biliary colic.
Yeah, what is biliary colic?
Biliary colic, it's been at right upper quadrant.
So the
Right upper.
biliary colic, so can this patient who came with 2 days history of pain, can
Yes.
this be biliary colic or it's not biliary colic?
Time.
Yeah. So this patient, now coming back to this patient has 2 days history of pain. Can you brand this patient to have biliary colic or not?
Yes,
So normally a biliary colic patient, okay, when does
Yes.
the pain start? When will the pain start?
yes. 3 days.
No, means when I say when, after taking food, when will the pain start approximately?
2 hours.
Exactly. So it starts usually around 2 hours. That is the time food from the stomach reaches the duodenum. And the pain is because the gallbladder is contracting, okay, and one of the stone comes and blocks the cystic duct. And the gallbladder tries to contract, but it cannot empty. That is why you have this pain. And this pain usually lasts for 2 to 3 hours maximum, and then it settles. If the pain continues for longer time, it is a biliary colic to start with, but it has now gone into cholecystitis.
Yes.
Yeah, so that is the biliary colic. Now let us come back to this patient. You got the history from the patient. As per the history, patient doesn't have any comorbidities, no vomiting, no loose stools, fever for 24 hours, right hypochondrial pain for 2 days. What next?
Yes. I will examine the patient.
Okay, what specifically you will check in the examination?
I will examine his sclera, vital signs, looking ill or dehydrated. Inspection, I will inspect the patient. If there is jaundice, if any mass in the abdomen, I will do palpation.
So you examine this patient. If at all, if you're thinking that this patient has acute calculus cholecystitis, okay, what specific sign you will elicit? What will you find in the abdominal examination?
Right upper quadrant tenderness.
What is it called? Or is it
Murphy's sign.
Excellent. So you went there and you feel the abdomen and you see that there is a diffuse globular swelling. You feel that you are palpating the gallbladder.
Yes.
What do you think?
It's a suspicion of cholecystitis.
Okay. So why does so normally in when you have cholecystitis, why does the gallbladder distend and why are you palpating it?
I don't understand you.
No. So in other words, okay, if this patient had come to your clinic, okay,
Yes,
come to your clinic and basically patient's history is just jaundice and you are examining his abdomen and you feel the gallbladder, you can palpate the gallbladder. What does it tell you?
Courvoisier syndrome.
Exactly. It's Courvoisier's law. What is Courvoisier's law?
It's a palpable gallbladder plus pain plus jaundice.
So if the gallbladder is palpable, as per the Courvoisier's law, what is it because of?
Because of if there is a obstacle in the pancreas.
So you mean, so if the gallbladder is palpable in a jaundice patient,
or there is a gallstone, impacted gallstone.
so what is more common? When you have a palpable gallbladder in a jaundice patient, you are dealing with a cancer or a stone disease?
Cancer.
Exactly. But in this case, if you palpate the gallbladder, do you suspect cancer or it is something else in this particular patient?
I will suspect cholecystitis because acute cases.
Acute, so it can be, So what is it called? When you have a stone impact on the gallbladder, which is distended like this, which you are palpating, what are all the possibilities?
Meridzi syndrome.
No, not Mersey. It is either a mucocele of the gallbladder or a pyocele of a gallbladder. Isn't it?
Yes, mucosal.
Fine. So you examine this patient, and patient has a palpable gallbladder which is very, very tender. Rest of the abdomen is normal. What next?
I will request blood test, the blood cells,
Okay.
liver function test, kidney function test, and ultrasound abdomen.
So
Ultrasound.
you see in the liver function test, you see that the bilirubin is elevated, ALT is elevated, ALP is elevated. What do you think?
It's there is an obstacle in the common bile duct by Meridzi syndrome or a calculus in the common bile duct.
Okay, fine. So this is the blood test you have. What next you will do?
Ultrasound of abdomen.
Okay, so it is at the middle of the night. There is no sonologist there. Anything else you want to do?
I will do admission patient. Nothing peroral, MPO, IV fluid, TVT and stress ulcer prophylaxis, antibiotics.
No, my question is, this patient has come in the middle of a night with severe pain. Okay,
Yeah.
you still have a differential diagnosis of perforated peptic ulcer, you
Yes.
know, acute cholecystitis. When
I will
ultrasound
request
scan is-
X-ray, chest X-ray.
okay, anything
abdomen
else?
X-ray.
Anything else you can, which can give you a diagnosis straight away? What is the next big investigation you can ask? A CT scan,
CT.
isn't it?
CT scan, yes.
Yeah. So
But
one thing,
ultrasound,
yeah,
ultrasound.
absolutely. So, but what I'm telling is, if someone gives you a situation where you cannot do an ultrasound scan, in
Yes.
a patient coming to A&E, you cannot wait until the morning, not knowing what is the diagnosis. Okay, by
Yes.
the time patient can deteriorate and die. Yeah.
Yes.
Right. So in this patient, there was, for some reason you don't have a sonologist, and the A&E doctors have already done a CT scan, and this is the CT scan. Have a look and tell me. What do you see here?
I will see at the standard
No, read the CT scan. You need to read it.
CT. Yes.
Is it a CT or an MRI?
It's a CT.
Okay.
CT with the IV contrast.
Okay. What phase? Is it arterial phase, portal venous phase?
Arterial. I think arterial phase.
Is it arterial phase? What will you see in arterial phase?
It's a portal phase.
Yeah. So in the arterial phase, this is the aorta. The aorta will be very bright, isn't it? This is the portal venous phase. And what
Yes.
section is this? Is it the axial, coronal, sagittal? What is it called?
It's sagittal.
Is it sagittal? This is axial. Yeah.
Axial.
This is an axial section. When you see, like if you have sliced like this, that is called as coronal section. Sagittal section is when you see the spine, when the body is sliced like this. Okay.
Yeah.
So now read
Yes.
the CT. What do you see here?
I'm not expert, but I will.
Yeah.
I will try.
Mhm.
I look here that distended gallbladder
Mhm.
with thick wall
Mhm.
enhanced.
So looking at the CT, what is your diagnosis?
I'm not
That's fine.
radiologist.
You tell what you know looking at the CT.
Yeah. Yes. Okay.
What do you think? Now, what do you think? You told that, okay, gallbladder is distended, which I agree. What do you see around the gallbladder?
Pancreas.
No, pancreas is here. Means surrounding the gallbladder, you have some haziness, isn't it? What do you call it as?
Omentum.
No, it's basically pericholecystic stranding.
Expanding. Yes.
Yeah. So this is
Stranding. Yes.
yeah, this is a typical finding of acute cholecystitis. Yeah.
Yes.
But do you think it is because of a stone or not because of a stone?
I think because of stone.
But
Not.
why can't we see the stone here?
Elucid, not seen by CT.
Okay.
Maybe I will see after by ultrasound.
Okay. So how many percentage of gallstones can be picked up in a CT scan?
I don't know.
Only 10%. Okay.
10%. Okay.
10%. So if you have done an ultrasound scan for this patient tomorrow, and if he had a stone, what specifically you will look in the ultrasound scan? What is a typical sign which will tell that, oh, it is a gallstone?
Thickening of wall.
Yeah.
Impacted gallstone if
No.
impacted.
How does a stone appear in an ultrasound scan?
Stone appears hyper-echoic.
No. So basically, you will see a posterior acoustic shadow.
Acoustic shadow, yes.
Exactly.
Yes.
So you will see both the stone and the gallbladder polyp will look the same in an ultrasound scan. If it is a stone, you will have a shadow. If it is a polyp, you will not have a shadow. Clear?
Yes.
Fine. So what is the treatment for this patient? So you have a patient with the CT report comes back now telling that patient has acute cholecystitis. Okay. And patient has dilated intrahepatic biliary radicals and an LFT showing deranged liver function test. What is the management?
Yes. This patient has a dilated intrahepatic duct.
Mm-hmm.
We have to confirm it by MRCP or do ERCP, diagnostic and therapeutic.
Will you do a diagnostic ERCP to look for a stone? What is the problem? So when you say diagnostic, so you're suspecting a stone here, will you put a patient to an endoscopic cannulate the pancreatic duct and do a dye to see a stone? Will you do that?
No, I will do MRCP.
MRCP. If at all, if the CT scan itself showed that they could see an radio opaque stone in the distal bile duct, will you still do an MRCP or you don't need an MRCP?
No, I will do directly ERCP to relieve the stone.
Okay, that is fine. So imagine this patient, this one showed a stone in the distal bile duct, okay, and you are booking for ERCP.
Yes.
So they have done the ERCP and the stone is removed. How are you going to deal with the gallbladder now?
Gallbladder, according to the guidelines of Tokyo 2018, I will do cholecystectomy.
Okay, by this time you did the ERCP, it is already 4 days old. Are you still happy to do a cholecystectomy?
Yes, till up to 7 days.
Okay, so how do you perform a safe cholecystectomy in this patient? Tell me the steps.
Lab cholecystectomy, I will first after putting my port, I will retract the gallstone. If there is a adhesion, I will do adhesiolysis and explore whole abdomen, and I will retract the gallbladder from the fundus and superiorly, and laterally I will retract the amphibiolum, and I will try to achieve critical.
Fine. So this patient, you go in, the gallbladder is super tense. You can't even hold the gallbladder. What will you do?
Yes, I can decrease the pressure of gallbladder by putting various needle.
Good. You aspirated the gallbladder. Now you are trying to push. You are trying to dissect the hepatocystic triangle, but you couldn't achieve the critical view of safety. It is all frozen. What will you do?
We can convert to open cholecystectomy. Or
anything you can do laparoscopy itself before you convert. What is the problem of doing an open cholecystectomy in this patient at that point? So you decide you can't see a critical view of safety, you decided to open. What are all the problems when you do an open cholecystectomy?
to achieve a critical view of safety.
Okay, no, I'm asking what are the problems of doing an open cholecystectomy compared to lap cholecystectomy?
Time,
Okay, one is the time, second.
common bile duct injury.
No, so that is there for everything. So when you do an open surgery, one is of course patient will have a big cut and pain. Most importantly, when you do such an infected case through an open wound, there is 50% chance that you will develop wound infection. Okay, and
Yes.
30 to 40% chance that these people will come back again with a big incisional hernia. Okay, that is why
Yes.
we don't try not to do. So when you
Yeah,
don't
you
have
yes.
tell me,
I can do tube cholecystostomy
okay, that is one option. What else?
and interval cholecystomy.
Okay, that is one. But why can't you bring down the gallbladder from that? When will you do a subtotal cholecystectomy then?
Yes, for partial cholecystectomy.
Yeah, you can do in this case. So when you can't achieve a critical view, bring the gallbladder from the fundus, open the gallbladder, there will be a stone impacted in the neck, take out everything, wash out, and then if you can go down or else wherever you can, just staple it or you can suture it or you can put whatever, you can put
Drain,
an endo loop and then put a drain and come. Okay,
Yes.
I'm going to stop here. Okay, how did you
Yeah,
do, Nadej? You did well?
Huh?
How did you do? How did you perform?
This patient, I will do by laparoscopic.
No,
I try.
No, I'm asking, I'm finished the scenario now. So
Yes.
how did you think that you performed in my questions now? Did you do well?
Yes.
Okay, good. So yes, you did well. You did well. Again, there are a few things which you need to be very careful. So again,
Yes.
in this scenario, you know, this consultant interview is something where the owners of the hospital, okay, or the owners of the healthcare system are trying to come and pick up the most talented person to deal with their patients safely. This is the whole idea of this, okay? And we want, or they want, the best of the best surgeons rather than people who are not confident or not knowing what they are doing. So another important thing you need to express in this interview process is maturity. You need to behave in a mature way that you have been a consultant for quite a long time. So that is another thing you need to say. So in this case, when I told, okay, patient with an acute abdomen coming at, sorry, just a minute, coming at middle of a night with pain, you need to tell that I am very concerned about this patient. Okay, the top differential diagnosis running in my mind are these things. I would proceed by taking. So you never told that this patient needs antibiotics, this patient needs fluid resuscitation. Yeah, those things are another important things which you need to tell, which again, I'm pretty sure once you do more and more practice, more and more understanding of these scenarios, you will get to know. Okay, right. So this is something about, so Adil did one chibe and I did one. So this gives you a taste of how an interview question would be. From this point, I am going to continue my last few slides. I'm going to present few more, okay? And then we will open up for the question and answer session. Yeah, just a minute. Okay. Yeah. So having done this, exercise, and congratulations to whoever had volunteered. This is very, very important. So in this exam, unless you volunteer and open your mouth and speak, you cannot, succeed in these exams. Okay. The reason being, we all, when you close your mind and think, you all know what you are doing. Okay. You all know what you will do. But when you want to come and speak, that is where all the problem comes. And in the exam, you have to watch the examiner eye to eye, and seeing his face, you need to answer. So this all comes with a lot of practice. It is not just the knowledge, but several other important things you need to cultivate. And one solution which we could offer from you is our SCFHS General Surgery Consultant Interview Training Program. So this is basically a structured training program where we will be exactly following what we have been doing for FRCS exam in the United Kingdom. Okay, and our main objective is to build the confidence first. Whenever a question is asked, you need to switch on your camera, come and talk. Second thing is to refine. You all have surgical skills. Like, you know, Ajit would do a lap cholecystectomy even on a difficult patient, but we need to know and pinpoint and identify the critical things, which is very, very vital for the safety of the patient. So to refine your surgical skills, and thereby means, you know, and then discuss and develop your knowledge, develop your confidence, develop your language, thereby you go, plan a date, give the exam, succeed. The worst thing is, after failing in the exam, you're not preparing for the exam, going there, you have taken leave, and then you fail, then come back, and you think that, oh, there's only one more option available. How am I going to prepare? It will become you will become very stressful. Your first attempt, you do all the preparations, you do all the sacrifices to prepare, give the exam confidently and clear, and that is where we could help you. Okay, and as I told, we have our expert faculty members. So I will be one of the faculty from the United Kingdom side, and I have few more colleagues who are interested as well. And you will have your local colleagues and the senior faculty from Saudi who will be helping you and guiding you through a structured surgical training. And we will be conducting mock exams. This is a taster viva session where I didn't stress you, I didn't ask difficult question, and I have been quite very kind. But the actual exam might be very, very strict. Some examiners might be very rude. Some examiners' language might be very fast that you can't understand. So those things all will improve when you get exposed to multiple people with multiple language background and the questioning methods. So by doing all these things, you get so much used to this practice that on the day of exam, you should think that, oh, it's like any other thing which we have been doing for the last 2 months. Okay. And apart from this kind of one-to-one training, as I told, we give you a library access which has the essential study materials in the form of PDFs, and we will give lots of recorded sessions close to 35 hours to 40 hours, which are all a recorded session from our FRCS thing, where you will listen to the recordings of what we did now, where the examiner will be questioning, the candidates will be answering, and how the feedback are given. So this will again give you an opportunity to understand the different types of scenarios you could get in different specialties. And of course, this you can access the content anywhere through your app or your phone, and you can go through it. And as I told, the most important thing for success here is not your knowledge, not your surgical training you had in these many years, but the essential thing is the technique. You have 30 minutes to prove who you are and to prove that you are an apt candidate to become a consultant in Saudi. In that 30 minutes, you have to express whatever you had trained in the last, whatever training program you had. So the essential thing is you need to know how to talk, what to talk and what not to talk, and use the 30 minutes opportunity to sell yourself. You need to sell yourself to the examiner, telling that, oh, he is the best candidate we were looking for. Okay. And again, as I can see, and you would appreciate, many of you don't have English as your first language, but you all speak well. I'm not criticizing or anything, but this exam will happen in English. So again, more and more you speak, more and more confident you become. And that is one of our primary objective. Our primary objective is, instead of me putting a slide and talking, and you listening to it, and me not knowing what you know or not, rather, we will make you speak and you learn by doing, rather than me dictating what is needed. Okay, so we come, we don't teach, we put the scenario, you talk, we will pick up what is wrong in you, in your language and how you present, and we tell this is the right thing, and you go. And then you go back, you see the recorded sessions, and you listen to yourself on how you prepared, and then listen to others. That's again a very good way of learning how others are presenting, and then gain the knowledge essential for this. Okay. And and as I told, this course, I'll come back to the schedule. So we also conduct mock exams where people come, and here I was telling what is the right answer and wrong answer, but in these mock exams, it will be time tested. There will be a time which is running on the corner. They will be questioning you. We will put the feedback, and we'll give you the mark sheet at the end of the thing. So So this is what we are will be aiming to in doing our course. And as you know, we have already advertised our first course, which is our first of its kind for the SCFHS exam preparation. And we are aiming to conduct at least 3 or 4 courses in a year. All the details will be available in the PrepMedico website. And this is our first course. And today we made this orientation session, which is open to all, so everyone can know. From next week onwards, from Saturday, every Saturday until May 3rd, we will be having sessions. So these sessions, everything will be happening online. And we will be having a closed group where all the communication and teaching will be happening in the chat. And these sessions will run for 2 to 2.5 hours. And you come, practice, and go, and you will get access to all these recordings, as well as a big chunk of recordings for you to revise, including what textbooks, what syllabus, as well as previous recordings. As I told, you all need to know what are the common causes of failure even before you appear for the exam, so that you need to know what is your strength and what is your weakness. Some people's strength will be knowledge, but their weakness is can't speak. For some, they can speak very nicely, but they will not have knowledge. So you need to pick up in the beginning only what you are lacking and focus on the weak areas rather than just sharpening whatever is your strength. If you know how to speak well, but you don't know the knowledge, you cannot be coming and boasting that, oh, I can speak well, but not knowing the basics. On the other hand, if you know all the knowledge, I have studied 15 textbooks of surgery, but if you can't speak, doesn't matter, it's not useful. So you need to know what is the appropriate preparation for this. You need to have a smart preparation rather than a difficult hard work. And the common reasons are, of course, an inadequate preparation, lack of structural clinical case preparation and discussions, poor time management. You'll be wasting time telling very long answers. The examiner wanted to ask you 30 questions, but you would have answered only 10 questions. That's another thing. Most importantly, communication skills and practical exposure. So we strongly believe, looking at how we made the FRCS program very successful in the UK, we also believe that the consultant interview exams in the Saudi Arabia could be made in a very simple manner, and people can clear this exam in an easy fashion rather than struggling and worrying about this, using our time-tested techniques in United Kingdom. Okay, and final tips and tricks is, you need to, once you have a date, you need to have a study routine. You should not find a time to study, rather than you need to find a time to do other works. Okay, the study time should be in your routine. Okay, and you need to know, again, as I told, smart preparation matters. You cannot be taking a book and studying from first page to last page. You need to know what are the common scenarios in trauma, oncology, emergency, to know and master that areas. And you need to practice. You need to speak. You need to run the time on the other side. Make sure you complete a viva. Okay, and of course, get advice from faculty members like whoever are here. Speak to people who already cleared the exam. Speak to people who had recently cleared the exam, thereby knowing whatever you need to know for this exam. Okay, so to conclude, language, knowledge, training. You will get this exam easily sorted, and then once you clear this exam, the world is open for you. You will have plenty of professional opportunities, better quality of life. You come to different countries, and you will be an excellent surgeon. So this is all I want to tell from my side, and let me open the floor for discussion or any questions if you have. Do you have any questions, guys?
Feel free to ask question in English, French, or Arabic, no problem.
Exactly, don't worry. Yes,
Don't worry,
Mohammed,
no
tell me.
First of all, thank you for this tester, Viva, and I feel that my appetite is widely open. I can eat a lot by now, although it's Ramadan.
Yeah.
Okay. My question is, can you please clarify the difference between the consent and the informed consent again?
Right.
So the consent, this is what you discuss with your patient, is verbally, but the informed consent, it should be written. So what will you do? What type of procedure? For example, lab or open, and you should stuck to this consent, and what are the possible complications. And here in Saudi Arabia, you need to do it both in English and Arabic, and should be signed by the patient, the doctor, and the nurse witness. And this is medical legally paper, very important.
So for the rules in Saudi Arabia, all consents should be informed consents.
Yes.
Right? Okay. Thank you. Thank you.
Welcome.
Hadij, you have any question? I saw you raising your hands.
When the session start?
So this session is starting from next weekend, coming Saturday.
Next hours? Like
So
today?
so we are planning to do what time, Shaib, in the Saudi Arabia?
For Ramadan, we are trying to organize the sessions in the morning. The idea is to make people comfortable during the day and let them comfortable by the end of the day for Tarawih Salat for most of us. And after Ramadan, inshallah, it will be by the end of the days. Once the group complete their subscription, we will have a WhatsApp group to discuss all these details about the hours and the details program, first session, second session, the timing, discuss if there is, for example, not availability of the faculty or not availability of all the candidates. We can discuss all that in details.
Yeah. Yes, Hadij. Tell me, Hadij.
In Ramadan, there is a session, or there was a session? There will be
in the morning.
morning. What time?
It can be between 10 and 12 KSA. That means 8 and 10 in Algeria.
Yes.
So what
Mais
how
le temps, on va adapter le temps fonction les candidats, fonction le nombre de candidats et fonction la discussion. C'est function of discussion of all the group, which is the best for all the group.
Exactly.
We are flexible.
So what we
How
will
long?
do is
3 months? For 3 months, the session.
8 weeks.
8
weeks.
8 weeks.
We will have 7 chapters, which is trauma, general surgery, breast, endocrine, colorectal, hepatobiliary, upper GI. And the 8th session is mock viva, which is in French is examen blanc. It is simulation of the exam seriously with faculty and just questions without feedback. And by the end, you will have the feedback and the note appreciation.
But in the session there is a cases or cases.
Which?
For example, the physician the cases
For example, I will explain to you. For example, next week we may have the session of trauma with the Dr. Adel, inshallah. So you will have 2 to 3 hours of clinical cases of trauma.
Okay.
The idea is you need to work your own English. You need to read. We won't teach you to read. To have the standards. This is your job. It's not our problem. Our mission is to put you in training. We will have, for example, a group of 4 or 5, as we did this taster today. We will cover all the topics in trauma and one by one. First clinical case with feedback, second clinical case with feedback, third clinical case with the feedback. And within 2-3 hours, we will try to cover the most of topics chapter by chapter. And this is the idea. We will give the max of chance to have the most common clinical cases in the exam from previous exams, and even more better to give you all the tools to answer the date of the exam for such clinical case.
Thanks. Thank you.
Welcome.
Yeah. So as Shaib told, once we have the candidate, we already have 3 or 4 candidates who are registered. So we will have a group where, because during Ramadan and different people are from different countries and the timing is different, we will have a close discussion amongst us to decide what is the appropriate time, and if the faculty is available at that particular time, we can do it during this time. But once we move on out of the Ramadan season, we can fix a particular time. Again, as Chaib told, we are very flexible to change the timings. As long as every candidates are happy and faculty are happy, we are happy to increase one or more sessions. If we find someone who is very, very weak, we may tell that, oh no, you are not there. You have to postpone your exam. This is not good. Or we will tell you have to come and do some additional training and stuff. And although, say, for example, next week, if it's trauma, yes, you will be covering everything. And in 3 or 4 weeks time, you might forget. So that's why, this recordings will be given to you, and you can run like a YouTube. You can run it in a fast way to revise all the knowledge before you go to the exam. So once you participate this, I feel that you don't need to study any books. You just need to listen to these videos, revise what is important, correct your queries, putting a message in the group, and you should be fine. Yeah.
If you permit, I will speak about my own experience. Once I arrived here to Saudi Arabia, I searched everywhere and I didn't find any official resource about the books or videos. So every consultant, he gave me some ideas, some documents. But what I found, the video of the PrepMedico for preparation of FRCS. And finally, it was very similar to our exam here in Saudi Arabia. And I booked as observer with them in the FRCS course, and I booked for one-to-one session. And believe me, the fact to listen to the recorded videos and attend as observer, it was hugely beneficial, because you will learn practically and pragmatically. That means you will know the most important thing. For example, you have a case of trauma. Instead to read the book of ATLS, which will take 2 months, you will have all the clinical cases with the key answer and the training, and you will listen for the errors for the others, and you will learn from your errors and for the errors for the others. And it will need continuous work, continuous listening, continuous watching. But by the end, you will feel very comfortable. And as driving a car, in the beginning, you will be hesitating. And once you will do a lot of travels, you will be very comfortable. This is the same. This is human. And the opportunity that we are given here, in our library, you will have access to FRCS videos from previous sessions. And you have in the applications already 12 videos free in the applications available. And you have other books, and you will have your recorded. That means you will do the session and you will watch yourself after. I think it's an excellent opportunity to improve ourselves, to go further, to have an excellent level, to achieve the exam, and you will work very comfortably. Even before coming to Saudi Arabia, it's better to have the exam and come very comfortably without any stress.
So I think most of you here would have been in the WhatsApp group. Okay, if not, I think Chaib will share the WhatsApp group, and we have our Facebook group where we will be putting all the announcements. And if you have any queries, you can speak to our admin team, who will be very happy to help you in sorting out whatever problems you have related to joining the course or queries about the future courses and stuff. Yes, Mohammed, tell me.
Yes, for me and Dr. Muhammad, our exam will be by the end of this year. How long we will have the access to the library and the recorded sessions?
So what we generally do is, whenever we give you access, it's only for 3 months, because as I told, I will tell you the background of this. Coming from the UK background, we are strongly monitored for all the copyright issues and stuff. We will not be able to provide things to be downloaded, because many, say, for example, the images which I use, the contents which I take, this I can use only for teaching purposes rather than circulation or downloading. So we will be able to provide for 3 months along with the course registration. But if you want to extend the access, we still have opportunities. Although it may not be for completely free, but we can give you some subsidized price where you can get access to this particular course or that particular course, which we can do. Yeah. Good. So if Dr. Adil, do you want to add anything, sir?
Bismillah ar-Rahman ar-Rahim. No, I think the benefits of the course has been well highlighted. It's not the amount of knowledge you have in your brain, how you are going to conduct this interview and to get safely through the journey, which is not going to be a long journey. You'll have a half an hour. You'll be bombarded with 6 cases that you really need to be prepared very well to get through them very quickly. I think the course will prepare people to get this experience as lighter as possible.
Thank you very much, sir. Thank you. Anyone else has any questions? If not, we will wind off this session. And this recording, again, whatever we discussed will be available in the YouTube. We will share the link in the preparation groups. And if you want to share to your friends and colleagues, please feel free to share this for them to understand what we can offer. And as Taib told, I would request everyone to download our PrepMedico app, whether it is an iPhone or an Android phone, where we had put up close to like 13 or 14 taster sections. Each session is close to 3 hours. So 13 or 14 when it comes, that itself comes to around, say, 100 hours of meeting there. Sorry, 30 to 40 hours of recordings. You can have a look to understand the depth and the kind of discussion and what kind of feedback we provide. So that's again a good opportunity for you to know what you would be going through when you join our course. Yeah. Good. If you don't have any questions, probably we can close the session. And thank you, Chaib, for all the organizing and hard work in the last few months. And thank you, Dr. Adil, for joining us, sir. And hoping to have a very successful program. And probably we will act as an important, mediator to help people to become consultants in Saudi very easily. Yeah. Thank you all and have a very good afternoon and good evening. Thank you. Bye.
Thank you. Bye. Thank you very much. Bye.
Thank you.
Thank you.